Good afternoon. My name is Mike Ciarametaro, Vice President of Research with the National Pharmaceutical Council, and I'll be your moderator today. I am pleased to be here today to discuss how current regulations act as a barrier to value-based contracting. The genesis of today's webinar was a recently published MPC white paper on the challenges created by regulatory barriers in value-based contracting. Today's discussion will focus on 3 of the 4 regulations discussed in this paper, including Medicaid Best Price, Medicare Average Sales Price, and the Anti-Kickback Statute. To date, there has been a significant amount of discussion surrounding regulatory barriers. These conversations have often oversimplified the solutions to these regulatory challenges, as there are a significant number of important considerations. The first consideration is the population in which the value-based agreement is being used, as the challenges presented by traditional therapies treating large patient populations are different than those present for cures and durable therapies that treat targeted patient populations. The second consideration is what type of value-based agreement is being used, as the challenges associated with outcomes-based contracting are different than indication-based contracting, which is different than time-based solutions for financing cures and durable therapies. Third, what is the impact of regulatory changes on payers? How do changes to Medicaid Best Price financially impact Medicaid? How do changes to average sales price impact Medicare and private payers, which use average sales price to set reimbursement rates? Is it possible to modify these regulations in a way that everybody is a winner? Then finally, we have the anti-corruption regulations, which are not just a single regulation, rather they are a series of regulations that include both the Anti-Kickback Statute and START. We are fortunate today to have a panel of speakers that will explore these considerations. I will begin by exploring the role of regulatory barriers in value-based contracting for traditional therapies. I will be followed by Mark Trushine, Strategic Director, NEWDIGS, MIT Center for Biomedical Innovation, who will explain the role of these barriers in value-based contracting for cures and durable therapies. Following Mark, we have Matt Salo, Executive Director, National Association of Medicaid Directors, who will provide the Medicaid perspective and highlight the need for a comprehensive solution. Then finally, we have Tina Olson-Grande, Senior Vice President of Policy at the Healthcare Leadership Council. She is going to discuss the good work that her organization has done on anti-corruption regulations. I will begin by reviewing 2 examples from the MPC white paper titled Regulatory Barriers Impair Alignment of Biopharmaceutical Price and Value. This paper is available on the MPC website. This study used a case-based approach that incorporated blinded biopharmaceuticals currently on the market. Therapies were selected based on their ability to highlight underlying regulatory challenges. Please keep in mind that while the numbers are realistic, all contracts are hypothetical and intended to elucidate the role of regulatory barriers. My first example will focus on the impact of Medicaid Best Price on outcomes-based contracting. For branded therapies, Medicaid Best Price is calculated as the larger number of 23.1% or the highest rebate given to any payer, provider, or other eligible entity. The key concept here is that if a rebate is offered to a payer that is higher than 23.1%, then this rebate becomes the mandatory discount that must be offered to all Medicaid plans, regardless of therapy performance. One final point here is that both outcomes-based and indication-based contracting rebates would be included in the determination of Medicaid Best Price. In our hypothetical scenario, a payer requests a 20% flat rebate to provide formulary access for a biopharmaceutical. However, the developer believes that the value of their therapy means that a 20% rebate is too high. As a compromise, the payer and developer agree to set up an outcomes-based agreement using hospitalization. The compromise contract includes a 15% flat rebate, In addition, for each hospitalization in excess of the clinical trial, the payers reimburse both the full drug cost and the hospitalization cost. Other key assumptions include that this payer represents about 5% of all sales for this therapy, while Medicaid represents about 20% of all sales for this therapy. So why would a developer and a payer enter into such an agreement? The answer to this question is that the contract creates value for both parties, which can be seen in this chart. The x-axis represents the percentage of hospitalizations, while the y-axis represents the percent rebate, which varies as a function of hospitalizations. For the manufacturer, the contract reduces the cost of access as long as the hospitalization rate remains below 14.5%. This reduced access cost is seen in Area A. For the payer, it provides financial protection against costs for hospitalizations in excess of the clinical trial results. This financial protection is seen in Area B. However, Medicaid Best Price limits the amount of risk sharing that can take place, as hospitalizations in excess of 15.7% will set a new Medicaid Best Price. The area impacted by Medicaid Best Price is shown as C in the chart. For example, a 16% hospitalization rate results in a 23.9% rebate, which is just above the 23.1% floor. This slight increase above 23.1% raises the effective rebate to 27.1% once the additional rebates to Medicaid are considered. This is equivalent to a $16 million annual increase in cost, regardless of therapy performance. This incentivizes the developer from sharing risk above the 23.1% rebate and acts as a natural cap on risk sharing. The second example will look at the impact of average sales price on indication-based contracting. When a medicine is administered in the doctor's office and the physician purchases the medication, the physician is then reimbursed by the payer. This is called a buy and bill system. Medicare average sales price, also known as ASP, is used to set reimbursement rates for Medicare buy and bill. In addition, many private payers use ASP to set their reimbursement rates for buy and bill. ASP is a volume-weighted average of all relevant rebates provided by the manufacturer within a given quarter. The second important feature of ASP is that it lags by 6 months, meaning that rebates provided in the first quarter determine ASP in the third quarter. Both outcomes and indication-based contracting rebates would be included in the ASP calculation. Our second example is based on an oncology therapy with 3 different indications, each with a different level of value. Buy and bill is the dominant way that this therapy is reimbursed. Table 1 illustrates why there is a need for indication-based pricing from the payer perspective. The first column highlights how utilization was distributed across the 3 indications. We calculated the value-based price for each indication based on the standard of care. The value-based price of the medicine was $20,000 per month for the first indication, $8,000 per month for the second indication, and $9,000 per month for the third indication. Broken down by indication, comparing ASP-based reimbursement with the value-based price revealed that the payer saved $9,700 for indication 1, while overpaying $2,300 for indication 2 and $1,300 for indication 3. When multiple indications exist, it is not possible to fully align price with value on an individual payer basis, as the utilization mix will vary from one payer to the next. In the above example, the payer overpaid $1,000 per month for the therapy. A different payer with a different utilization mix could have just as easily underpaid. The value of indication-based contracting is to provide a mechanism to address this mismatch. Now, let's suppose that the manufacturer had put in place an indication-based contract that paid a rebate based on the utilization mix and the value-based price for each indication. What would happen to ASP? Well, 6 months after the rebates are implemented, ASP plus 3% reimbursement would drop to $9,579 per month. Assuming that physician acquisition costs remain constant at $10,000 per month, the physician would lose $521 per month per patient under a buy and bill approach. For a physician treating 10 patients per month, they would lose slightly more than $50,000 per year. Under this scenario, a physician is unlikely to use this therapy, which creates a disincentive for the developer to use indication-based pricing contracts when buy and bill is the dominant method of reimbursement. These examples highlight the need to modify Medicaid's best price and Medicare's average sales price regulations to accommodate outcome-based and indication-based contracts. I will now turn the presentation over to Mark Trushine, who will discuss the impact of these regulations on curative and durable therapies. Thank you.
Thank you very much for that introduction, and hello to everyone on this webinar. I'm Mark Trushine, Strategic Director of the MIT NEWDIGS program, of which the project focus is one of our consortium, which deals with financing and reimbursement of cures in the United States. At NEWDIGS, we innovate how we innovate. We work together across the silos of payers and patients, of developers and other organizations such as policy groups and other advocates to try to evolve the system to make it faster, smarter, and better in a way that advances sustainable patient-centered innovation that works for everyone, from regulators to payers, from patients to developers. So you see that our mission statement is to deliver more value faster to patients, but in ways that work for everyone. In our Financing of Cures initiative, we address financing the value of durable therapies. That means for us, creating precision financing solutions for durable and potentially curative therapies with large upfront costs whose benefits accrue over time. We are not on assessing or setting the value or negotiating specific prices for specific products. That is a topic of value setting that is handled by many groups such as ICER, such as individual payer and developer discussions and negotiations. We rather at Focus concentrate on, given that a value has been set, it is likely reasonably high and therefore causes new kinds of financing challenges for durable therapies. And let me explain a bit on the next slide who we are in this particular project, and then how these financing challenges work out, and then how Medicaid Best Price causes some challenges for that. So our focus stakeholders path began back in 2017. We take a case-based approach where we've looked at blood disorders, ultra-orphan therapies, and cancer CAR T therapies. We've had over 50 organizations involved, including payers such as Blue Cross Blue Shield, Kaiser Permanente, Harvard Pilgrim Healthcare, and others. We've had a number of firms, both large and small, who are developing these therapies, from Avexis and Bluebird Bio and Regenerex to Merck and GSK and Pfizer, all part of this consortium, as well as organizations such as NPC, which is sponsoring this webinar, as well as patient advocacy groups, such as the Hemophilia Patient Society and the Transplant Patient Societies. As you see, we've had a process where we have first elucidated various issues, then begin to try to find new solutions to those through pressure testing, and then we're now moving into a dissemination and implementation planning phase. Okay. You may find much of our research by Googling MIT NEWDIGS Focus, and that will take you to our pages where we have many research briefs and coming white papers that will be available. Some of those items we'll be discussing today. Durable therapies create three particular financing challenges above and beyond what classic pharmaceuticals present. You'll see on the left-hand top slide that the pipeline of such durable cure and potentially curative therapies numbers over 900 in various phases of development, from preclinical to review and approval. We have estimated at MIT that by the end of 2022, approximately 40 of these will actually make it to the marketplace. These durable therapies will all share this pattern that's shown on the right-hand side, that whereas a classic medicine, we accrue the benefit and we pay for that value received, that value paid in the orange bars over time. For durable therapies, the blue benefit received, it still occurs over many years, but the payment for that will likely be upfront because these therapies are administered once and will be paid for once at that time of administration, whether that's a single dose or over a reasonably short period of time of 3 months to less than a year. So we have then, because of this different payment pattern, three new financial challenges. One, of course, is exactly that payment timing, that large upfront payment represented by the orange bar as opposed to pay as you go. But that's also then has two other challenges. One is a product performance risk on its effectiveness and durability over how many periods. Will it be a couple years or will it be a lifetime? For example, there will be some uncertainty about that, which we would like to see some financing approaches accommodate. And also there's actuarial risk with many of these therapies being for orphan diseases where it's not clear whether a given employer or even a reasonably sized plan will have one, two, or many such cases that will hit its financial statements and healthcare costs for that particular period. So I won't dwell on this more than this slide, but we have seen that three broad solutions and one new system model are emerging. We see short-term milestone-based contracts with under a year of duration, which generally don't hit Medicaid Best Price, but do to some extent. But more importantly, the multi-period, multi-year performance-based annuity style solutions, which would better match the benefits and address the durability concerns on the prior slides, trigger Medicaid Best Price concerns, which I'll go into in a minute. Population pooling, of course, helps with some of the actuarial risk. We will not discuss that much. And we also believe that in this complicated network of patients, providers, developers, and multiple lines of payers, that an orphan reinsurer and benefit manager approach that would replace much of the channel and intermediaries box there in the middle and arbitrate many of these challenges. There's an opportunity for that. If you wish to see more information, again, go to our NEWDIGS focus website for that. But let's move on to the Medicaid Best Price issue. So the precision financing we think of sees that a one-size-fits-all approach cannot work, that because diseases in therapeutic areas vary in their pattern of disease morbidity and also their population sizes, because payers differ by their funding sources, particularly this Medicaid public program versus private and even Medicare managed care programs. They have different sources, but also sizes and constraints legally, which Medicaid Best Price is certainly one of the most important. Providers and developers' financial needs and capacities also vary, as Michael showed in the prior examples, and the patient ability to financially participate could also inhibit access to care, although we will not talk about the role of copays today. The result is that performance-based risk, annuity risk, and payment timing risk vary by each of these payers, and Medicaid Best Price poses a barrier to efficiently accommodating that variety of needs and desires by each of these different payers for the different kinds of payer types and the cure types, whether those be oncology, the novel small drugs, the orphan disruptors, and what we call quantum leaps, which are the very large population conditions with curative therapies such as hepatitis C. So Many government pricing barriers actually are of concern, Medicaid Best Price being one, but also 340B drug discounting programs where the ceiling is set by Medicaid Best Price, and as Michael has already discussed, some of the average sales price issues. The primary concerns are that the government pricing does not clearly specify the treatment of these novel new contracting mechanisms, particularly think of a multi-year performance-based annuity approach, and that some interpretations have substantial impact on government pricing, which I'll illustrate with an example in just a moment. The end result is that manufacturers are generally avoiding these contracting that may create regulatory and legal financial risk, or greatly limiting the creativity and depth of discounts that they might be able to offer. And we'll talk about an example. So imagine the case first, and we'll come back to the calculations at the top second. In the case, so let's presume you get an FDA approval at some time point, and then relatively rapidly thereafter, you see your first patient, and you have $1 million overall price divided into simply two payments, one immediately in a $400,000 initial payment, and then one more than a year or maybe even 2 years later as a contingent payment to address both some of the benefits being accrued over that time to spread out those payments for payers, and also address whether the product is efficacious over that period of time. Here, let's presume that that $600,000 contingent payment is only 50% likely to be paid, meaning that half of the patients will still see an effective treatment at that milestone and half will not. This raises a number of issues. Could that $400,000 initial payment be treated as the best price? What is the best price initially before we have multiple years of rebate data available? So in that first 6 months where we've never seen a patient for more than 2 or 3 years other than in a clinical trial, what might we use or think of as what that best price for the total contract might look like? And is price change due to fluctuations in patient outcomes appropriate? What if we're just statistically lucky or unlucky with the number of patients initially who respond well to that treatment? What, in other words, if that 50% likelihood is 100% likely, or no one gets a rebate because luckily for the patients, everyone responds. Should we see the best price fluctuate from period to period as those statistical changes and expected statistical variations occur? And that implies not just overall, but what if there's something innate about the commercial population versus the Medicaid patients in terms of severity, perhaps, and therefore their likelihood of response? Should that affect Medicaid Best Price? Let's take a simpler example just to show how this might play out. If you think that the AMP method is full price with a best price method being what's the average expected, you would say, well, the average is, the AMP is a million, shown here as 1,000, and that the best price would be 400,000 plus 50% of the time we pay nothing and 50% of the time we pay $600,000. So that works out to a contingent average of 300. So 400 and 300 equals a $700,000 average best price. That discount would therefore be 30% and the net price $700,000. But one could imagine an interpretation under the current regulations where the best price is only that first payment of $400,000. That would be a 60% discount and trigger a new net price of $400,000. If you expected rather that we should do an actuarial estimate even early and say that the AMP is actually $700,000, that $400,000 plus that expected contingent payment, then the best price on an average basis equals that, and you wind up with your 23.1% AMP based discount that changes the net price to $538. Or you can do the worst approach, which is the AMP is $700,000, but still it's that $400,000 level, and the AMP minus best price then gives you a 42.9% discount, and again a net price of $400. This range of interpretation causes people concerns about what kinds of interpretation for a given state Medicaid investigator or plan might be interpreted, and therefore what are the obligations owed by the company from one place to another. So as you can see, Medicaid Best Price and the range of interpretations, even under the current situation, causes great variability in a situation where we already have variability we're trying to account for in the product itself with these durable cures. So it is, however, just one of multiple policy challenges where patient mobility, where the patient changes from one commercial plan to another, or from Medicaid to commercial or vice versa, comes into play as to who should then pick up those obligations in the future. The Medicaid Best Price we've talked about. The buy and bill margin is a serious concern, which Michael talked about. The stop loss and reinsurance impact, for those of you who looked at that network of payers, particularly for the self-insured employer types, has certain challenges about whether multiple years would be accounted for or lasered out in those kinds of contracts. There's cost and revenue recognition issues from the accounting standpoint. And some Medicaid programs that might like to participate in this may face state multi-year contract prohibitions and balanced budget issues that might be able to be avoided by Medicaid MCOs, but for state-funded plans may be problematic. So Medicaid Best Price is just one of many policy challenges. You also hear about several additional ones later today, but I hope this walking through how in a curative therapy context, Medicaid Best Price is causing many challenges for companies that want to do innovative things to benefit payers and patients are meeting regulatory government challenges. Thank you.
All right, great. Thanks, Mark. So this is Matt Salo with the National Association of Medicaid Directors, and my members are the folks in every state and territory who runs the Medicaid program. And I'm going to try to briefly explain why current prescription drug coverage and pricing policy doesn't work for us either. I think you may hear some slightly different takes on this, but I think it's important to get some of these perspectives across, given the role that Medicaid plays in the healthcare system. So I'm going to try to do this largely at 30,000 feet and without slides and without, I hope, acronyms. But just, quick background, people should know, Medicaid is the healthcare safety net in this country. It is actually also the largest health insurance program in this country. We cover 70+ million people. We spend $600 billion a year, and it's about 30% of the average state budget. Medicaid has evolved and grown quite substantially in its 50+ year history, essentially to fill the gaps that exist in the U.S. healthcare system. And one of the things that has also been true of Medicaid in its 50+ year history is that by design, it reimburses, or we reimburse less for essentially everything that we pay for in the healthcare system. So hospitals, nursing homes, doctors, dentists, no matter what sort of provider you're talking about, and I know this doesn't always make us popular, but no matter what service we're talking about, Medicaid generally pays less than Medicare, which pays less than commercial markets. And certainly, I will argue, prescription drugs should be no different in that concept. Now, I don't want to get caught up in the nomenclature of the quote-unquote best price, because I think, as we've talked about, there are a variety of reasons why it doesn't necessarily work well, sometimes for us, clearly for others. I would say that the important thing that we want to keep in mind is that whether it's quote-unquote best price or not, the most important thing for the sustainability of the Medicaid program is that for prescription drugs, we get a price that is low enough to be sustainable. And that can be quite a different thing than the quote-unquote best price as it exists in statute and in regulation. Because it's also important to remember that Medicaid, as the safety net, serves the most complex, the most frail, and the most costly members of society. We're the largest payer of long-term care. We are the biggest payer of mental health services, of behavioral health services, of HIV/AIDS services. No matter what you look at, we have the lion's share of the responsibility in the healthcare system. And one of the things that state Medicaid programs have been doing for many years now is really trying to drive comprehensive health system reform. And that looks at delivery system, trying to create a more holistic, coordinated, or managed system of care for the beneficiary, but also payment reform. How are we moving away from paying for volume and towards paying for value? And we've seen a lot of success in this in almost every area of the healthcare system except prescription drugs. A lot of the reasons have been hit on. I don't want to belabor them. It's the vagaries of the Best Price statute and regulation. It's the anti-kickback statutes and regulations that are out there. It's the lack of transparency in the market. But one thing that doesn't really get talked about much is, and this is what I really want to focus on, it's the fact that the quid pro quo, if you will, of Medicaid getting the quote-unquote best price is that Medicaid essentially operates an open formulary. So Medicaid is unlike any other payer in the country or the world in that if it's approved by the FDA, we have to cover it. And that, in many ways, simply doesn't allow state Medicaid programs the real market leverage to be able to drive value and to be able to get a quality, sustainable, affordable health system for the people we serve. And I think in many ways, things like the 21st Century Cures has kind of exacerbated this challenge because we are at a point in history where, let's face it, we are in a renaissance of innovation. We are creating cures and treatments and solutions to problems we didn't think possible 5, 10 years ago. This is an exciting time to be a part of American history in terms of life sciences. But this renaissance has outstripped our ability to think about how do we pay for these things in a comprehensive, thoughtful, and sustainable way. And we have certainly created scenarios where prescription drugs and other types of treatments are hitting the market, and I don't think there's anyone out there who can say that these things are being priced rationally in every case. And so the change that I will argue is needed starts very simply. We have states out there that are petitioning the federal government to say, we need to make some tweaks. We need to be able to look at this open formulary issue and say, we know this isn't working because there are drugs that we are covering that simply aren't any more effective than placebos or than existing products, and they're being priced at a rate that is clearly unsustainable and is jeopardizing access to the people who need it most. So states like Massachusetts and many, many others who are waiting in the wings to see how this conversation is going really need to see from the federal government a willingness to say, whether it's through the Section 1115 authority, whether it's through the authority of the Centers for Medicare and Medicaid Innovation. Personally, I don't care, but there needs to be some ability to say, we're going to bring some rationality and some thoughtfulness to how Medicaid is going to adapt in order to survive in a 21st century healthcare market. Medicaid has evolved and changed very, very significantly over the past 20 years, over the past 50 years. The prescription drug coverage and pricing policies need to adapt and evolve similarly in order to keep the program sustainable moving forward. So I will stop there, look forward to questions we have at the end, and I will pass the baton on to Tina.
Thank you, Matt. Hi, this is Tina Olson-Grandy with the Healthcare Leadership Council, and I'm pleased to be here today on behalf of the HLC, as we call ourselves. HLC has spent much time over the last few years on the health system transformation. Really, I love Matt's term, the renaissance of innovation. It's an exciting time to be working in health policy, and there's so much more value that can be brought to consumers and the system as a whole. And our member organizations are very excited about what's happening in healthcare today. The Healthcare Leadership Council, for folks on the phone who might not know who we are, is a coalition of CEOs that span all sectors in the healthcare industry. So we have the leaders from hospitals, clinics, health plans, pharmaceutical, medical device companies. We've got IT CEOs, distributors, drugstores, and we really come together collectively to promote policies that bring more value, better health outcomes at a more efficient price or more efficient delivery for all people in the United States, and ensuring that accessible, high-quality health care is the norm. So to achieve this mission, we very much believe that moving towards a value-focused system is where we should be headed. We have done much communicating with Congress and the administration on pushing for more value-based healthcare and value-based payment arrangements. And one of the ways that we do our communicating is through Hill briefings. We like to go to Capitol Hill. We do roughly one briefing a month where we talk about a policy topic of importance. And in this case, modernizing the federal Anti-Kickback Statute and Stark physician self-referral law was our kickoff Hill briefing for the year. We really focused on these two laws that our member organizations very much view as barriers to enabling more value-based payment models and integrated and care coordination models to flourish in American healthcare beyond the more limited demonstration programs that are coming out of the Center for Medicare and Medicaid Innovation. So we have engaged also heavily in communications with the administration. HHS Deputy Secretary Hargan is managing regulatory relief at the agency, and we have spent time talking with him about the need to modernize these fraud and abuse laws to enable value-based care to proliferate. It is clear to us that there is a strong interest at the Department of Health and Human Services in responsibly modernizing these laws so that care can be better coordinated to improve healthcare outcomes. I think most folks probably are aware that earlier this month, HHS through CMS issued a request for information on the Stark law, and we are also awaiting a request for information from the HHS Office of Inspector General on the anti-kickback law as it relates to care coordination and value-based care. We are working with many members of Congress to educate them about the need to modernize these laws as they relate to value-based arrangements. But we also equally emphasize that we are not looking to remove these laws from the books. There is a very strong case to be made that these laws should continue to apply where volume-based care is being delivered. But as we move to new models of care coordination, we are working extensively with members of Congress to educate them about the need to modernize given the types of system transformation that we are looking for. So HLC has convened a work group of many organizations in Washington beyond our own members to look at how to modernize these fraud and abuse laws in order to encourage more value-based care and payment arrangements to occur. We produced a white paper in February of 2017 that's been widely disseminated with policymakers here in Washington. And the white paper focuses on the Anti-Kickback Statute and the physician self-referral law and recommendations related to modernizing them as it relates to value-based arrangements. The recommendations in our white paper are really based on three types of criteria. Our recommendations focused on what's actually feasible, the impact of those recommendations on the system as a whole, and we also looked at recommendations that were timely in nature, meaning they can happen hopefully within the next 6 months to 1 year. So I think folks probably understand the basics of the Anti-Kickback Statute as it applies to healthcare. It basically is an anti-bribery law, a federal law, that prohibits the exchange of or offer to exchange anything of value in an effort to induce the referral of federal healthcare program business. And the OIG can issue safe harbors that would allow for certain types of activities to occur if the OIG believes that it isn't going to be a problem under the Anti-Kickback Statute. This statute applies to all stakeholders, so it applies to pharmaceutical organizations as well as medical device companies and hospitals, IT companies, really anybody involved in healthcare arrangements. It's a criminal statute with treble damages, so this is a very heavy law. It's a heavy hammer that comes down for organizations that violate it. The other law that we have focused on in our white paper is the physician self-referral law, also known as the Stark Law. This is a law that prohibits a physician from referring patients for services reimbursed by a federal healthcare program to a healthcare organization in which the physician or a physician's family member has a financial relationship, and prohibits the organizations from billing for those services. And again, like the Anti-Kickback Statute, CMS can apply exceptions under the physician self-referral law for very specific instances. And these safe harbors and exceptions are very important, but they really, if we were to continue in the current pathway of limiting safe harbors and exceptions to sort of very singular instances, it doesn't help us move more broadly towards a value-based system where you've got all the stakeholders working together in a fluid fashion to deliver care that is higher value because there's more ability to coordinate with each other. So although our organizations certainly appreciate the exceptions and safe harbors that currently exist, continuing in that sort of one-off fashion, as we call it, it really sort of continues the siloed element of delivering and paying for care in our country. So in our white paper, we've put forward regulatory and legislative options for the government to consider in terms of reducing the barriers as related to the Anti-Kickback Statute and the Stark Law. And I would note that we have taken a broad entity agnostic approach to our work, whereby we believe that safe harbors and exceptions for value-based care should be applied broadly and should apply to all stakeholders who are involved. Again, in the name of creating a more holistic and fluid system that will generate the coordination necessary to bring more value to patients and consumers. So we have a list of high-level solutions in our paper. I'm not going to go too deep because we're running sort of short on time, so I'll just go through them on our slides for our listeners. The first is we'd like to see more safe harbors and exceptions or guidance coming from the government that extend the existing Anti-Kickback Statute and Stark Law waivers that we currently see in the Medicare Shared Savings Program and for ACOs and other types of alternative payment models that are currently run out of CMMI. We'd like to see those safe harbors and exceptions given broadly to organizations that are operating both within federal healthcare programs and the commercial market, and are operating within strict parameters that are related to value-based payment and value-based care arrangements. We would also like to see clarification on how to establish, document, and apply the Anti-Kickback Statute and Stark Law's prohibition on using volume or value of referrals, as these payment models shift to measuring value as opposed to the volume of care being delivered. We have also recommended that we expand and revise the application of fair market value standards to account for new payment models based on the delivering of value to consumers and patients as opposed to volume. And also, we've asked for elimination or redefinition of the one purpose test for anti-kickback statute liability, and that it be replaced with a balancing test that would require the Inspector General to prove either increased cost or actual harm to a patient. And specifically for Congress, we have a great interest in seeking legislation that would grant OIG and CMS enhanced regulatory flexibility and rulemaking discretion to develop exceptions and safe harbors that are consistent with the broad policy objectives that would apply to all stakeholders who are engaging in these value-based arrangements. We also very much encourage Congress in the drafting of legislation to adapt the Anti-Kickback Statute, the Stark Law, as well as the Civil Monetary Penalties Law to really reflect what's happening in the healthcare environment now with this move towards more value-based care that's integrated among many organizations and really requires a lot of coordination and communication to make it work well. So the current state of play here at the federal level, I'll mention a few things that have happened recently. In April, the House Ways and Means Committee Subcommittee on Health held a hearing on innovation in healthcare. And during that hearing, members and witnesses discussed the need to shift to value-based care, and they discussed the associated barriers that are posed by the Stark Law and the Anti-Kickback Statute. Also in February, the HHS Office of Inspector General issued a solicitation of new safe harbors and special fraud alerts, and HLC as an organization did send comments into the OIG on the solicitation, and our comments were based on the white paper that I just went over for folks. And very recently, just this month, CMS issued a request for information on the Stark self-referral law. We certainly will be commenting on that in our broad way to discuss the need for all stakeholders to be given relief as it relates to value-based care arrangements and payment arrangements. And we are also aware that the Office of Inspector General will be also issuing a request for information as it relates specifically to the Anti-Kickback Statute and value-based arrangements. And lastly, I would note that we certainly have heard on many occasions from HHS Secretary Alex Azar that moving towards a value-based system is a high priority for this administration. And we do see a slew of RFIs coming out from this administration related to how to reduce barriers to enable value-based care to flourish. So we are quite pleased that we've seen the RFI on the physician self-referral law come out, and we are eagerly awaiting the RFI from the OIG on the Anti-Kickback Statute. And I'm sure for many on the phone, they're quite aware of the administration's blueprint on American Patients First as it relates to drug pricing. And certainly from an HLC standpoint, we have, in response to the RFI that came out associated with that, we have heavily emphasized the need to modernize the Anti-Kickback Statute as it relates to enabling organizations to enter into these value-based arrangements that will focus on outcomes, They will be risk-based, and they will look for a focus on the end product, which is a better outcome for the patient. So I will stop there, and hopefully we've got time for a few questions. Thank you very much.
Thank you, Tina. We are now entering the Q&A portion of today's webinar. I'd like to begin with a question for Matt. Matt, what do you see as the biggest roadblocks to Medicaid Best Price reform?
Well, as everyone has said, there are a lot of barriers here, but right now, I think that there are real-world feasible solutions within our grasp. And I mentioned the Massachusetts waiver. I think that's the first step towards, the administration really signaling that it's got to put some teeth behind its blueprint and saying, yes, here is a state that has thought very, very long and hard about how to do something different in this area. Let's let them try this. And I think I'd say one other thing. I think, one of the things we're hearing is that, states are being encouraged to sort of just completely blow up the entire Medicaid drug rebate program and just start from scratch. And quite frankly, I think that's not a solution that states are looking for either. And I think what states like Massachusetts are saying, and again, many others who are right behind them, is in many ways, in many parts of the drug coverage market in Medicaid, the existing law works pretty well. But it's really this revolution or renaissance in new treatments, in new types of science, where, quite frankly, we need a new covenant with the federal government and with the manufacturers to make sure that Medicaid is staying relevant. So I think the administration can improve this relatively quickly. Whether it does so or not, I'm not sure.
Thank you. Mark, what are the potential consequences for the development of curative therapies if relevant regulations are not modified?
So what you'll see is very few longer-term performance-based annuities come in place with discounts beyond the 23% level, which we're already seeing happen in the very first products by Spark Therapeutics and by Novartis. Both, it's clear they both feel constrained by the current discounting approaches. So doing for example, a 5-year program where in each year 20% of the payment would be done, so it adds up to 100%. Those sorts of deals just won't be coming forward, which would do a much better job of matching the benefits of these therapies with their longer-term payment structures. So I think that's the lost opportunity that we're seeing.
All right. Thank you, Mark. Matt, what is the biggest value-based contracting risk facing Medicaid?
Biggest value risk. Well, I think one of the things that Michael and Mark and Tina all talked about a variety of different approaches here. I think the challenge for us is defining what is value. And I think the challenge that we're seeing is when it comes to pricing. Right now, we're in a system where manufacturers essentially get to determine the price. And what I think I'm worried about a little bit is if they're going to start defining what value means and, trying to amortize the costs of a particular cure or a treatment over a 10 or a 15 or a 20-year window sounds very kind of intellectually appealing. Quite frankly, I've been around state government for a very long time, and trust me, we don't do real well with that kind of thing. All you need to do is look at underfunded state pensions to know that trying to push the cost of something that's not immediately affordable out into the 10, 15, 20-year window is not a recipe for solid financial management. So I really think it's how are we going to define what the value is and how do we pay for it?
Tina, quickly, what do you see as the biggest risk if the relevant regulations are not modified?
Thanks. I really think the biggest risk is that we will not see movement towards value-based payment and care delivery in this country. MACRA, which folks probably know is a physician-related rule that replaced the sustainable growth rate formula, requires physicians to be in full-blown alternative payment models, as they're called, in order to receive a higher level of reimbursement. That's not going to happen if we don't get some relief on the Stark Law. And on the anti-kickback side, we're certainly not going to see organizations like pharmaceutical companies and medical device companies be willing to enter into risk-based arrangements as it relates to finding the right product for certain types of patients and populations that enable more innovative, thoughtful arrangements to get us where we want to be with value-based healthcare. So without some relief from these regulatory barriers, I don't think we'll move beyond our value-based system at a speed that is acceptable.
Thank you. Today's discussion highlighted the impact of regulatory barriers on value-based contracting. These impacts provide a clear need to modify these regulations to better support value-based contracts. However, these modifications need to be done in a way that considers how Medicaid, Medicare, and private payers will be impacted. I would like to thank today's webinar participants for sharing both their time and their thoughts with us. Today's webinar will be posted on the MPC website within the next week. Finally, for those of you in the audience, your feedback is important to us as we do a lot of webinars. So please complete the forthcoming evaluation survey. Thank you, everybody.